Good evening, everybody, my colleagues, my professors, my friends. Today will be a wonderful, I think, webinar about heart failure. And this webinar of the American Society of Heart Failure through eminent speakers and CVREP board together with national faculty. I'll be with Dr. Hassanin, the board members, and we have a national faculty, Professor Magdi Abdhamid, Professor Ihab Ataya, and three international speakers, Professor Bickman Busquet is the professor of cardiology in Baylor College of Physicians, Texas Heart Institute, and she's a president of the Heart Failure Society of American Society of Heart Failure. And together with Dr. Scott Solomon, the professor of medicine in Harvard Medical School, also the board of the society, and Javed Butler, professor of cardiology, University of Mississippi, and also the board of the American Society of Heart Failure. Actually, today we'll have three speakers about international speak about the heart failure, and finally we will have a case with Dr. Ihab Ataya at the end. This is sponsored by Novartis and technically by ICOM company. Welcome all the group for the first time to be with us as a virtual. This is the virtual events. I call it a non-COVID webinar. We don't speak about COVID in this webinar. We'll speak about heart failure, particularly the reduced heart failure, preserved heart failure, and precision. And now I leave the mic to Dr. Bickman to introduce the society and the heart failure, American Society of Heart Failure, and the learning objective of this webinar.
Professor Sabi, thank you for welcoming us and for that introduction. I'm Bikram Baskurt. I'm professor of medicine, director of the Winter Center for Heart Failure Research at Baylor College of Medicine, and I lead the medicine department at the VA. I'm joined by my colleagues, the esteemed Professor Butler and Professor Solomon, as well as Professor Hassanin and yourself. In this exciting session. We were invited to participate as individuals from the US in participation to the session with CVREP, the Cardiovascular Research Education Prevention Foundation. I'm participating on myself, not necessarily representing the HFSA, but I am currently the president of the HFSA. So we're looking forward to this initiative, which I think is going to be quite exciting, with very complementary sessions. We will have Dr. Javed Butler setting the stage by talking about advances in heart failure therapies, Dr. Scott Solomon talking about the challenges of treatment for heart failure with preserved EF. I will then touch on the need for precision for heart failure. And then we're going to hear from Dr. Ataya regarding the essential intervention. So we look forward to this session and hope that it will be of interest to all the audience members and look forward to the discussion.
Okay, thank you, Bickman. Let's start, and remember that you should have questions, and we'll have 20 minutes of the speaker and then 15 minutes discussion. And please, the attendees send the questions, and then me and Dr. Hassanin will discuss with the panelists and the speakers these questions, and we'll try to answer. We'll start by Dr. Javed Butler about advanced heart failure, particularly reduced heart failure with reduced ejection fraction. Dr. David?
Can you see my screen?
Yes, we see it very well.
Great. Well, it's an absolute pleasure and an honor to be presenting today. The topic of my presentation is advances in the management of patients with heart failure reduced ejection fraction, and I will focus on 3 or 4 trials that have recently come out, although I have to say that while I am giving this presentation, most of what I've learned about heart failure with reduced ejection fraction is from the trials that Dr. Solomon has conducted. So we all have learned a lot from his efforts, and I'm sure that we will learn more in the Q&A session as well. These are my disclosures. So this is sort of a classic pathophysiology diagram that Dr. Brownwald had drawn in one of his review papers. And the concept here is that if you think about, a person who does not have heart failure, has normal ejection fraction, some insult happens, whatever it is, myocardial infarction, myocarditis, whatever it is, one would expect that, say, the ejection fraction dropped from 60% to 35%, that in the absence of more insults, the ejection fraction should then remain at 35%. But we know that if we leave these patients alone, the ejection fraction will not stay at 35%. It will go to 32% and 30% and 25% and will continue to go down. So the question is that if there are no recurrent insults, why does the ejection fraction keeps continue to go down? And the answer to that is that once the ejection fraction goes down in the first place, in order to maintain hemodynamics, we have all of these neurohormonal systems that get activated, the sympathetic nervous system, renin-angiotensin system, aldosterone system, so on and so forth, to maintain hemodynamics. Well, in the short term, that's great. That's great when you have, say, diarrheal illness, or if you have bleeding or something like that, because in 7, 8, 10 days, all of this will reverse. Well, that doesn't happen in heart failure because the low ejection fraction and abnormal circulation continues for weeks and months and years. And there is constant activation of these neurohormonal systems, and then leads to adverse cellular effects, organ level effects, hemodynamic effects, and eventually worsening of the heart function, worsening of the kidney function, more sodium and fluid retention, fibrosis, risk of certain cardiac death, so on and so forth. So when we sort of understood what leads to the progression of heart failure is when we entered this sort of the golden era of heart failure therapy with neurohormonal antagonists. And from mid-80s to say early 2000, this was the construct we had, that everybody should be on an ACE inhibitor and beta blockers, and if they don't have a contraindication, should be on aldosterone antagonists if their potassium and creatinine can tolerate it. And that basically became the stable neurohormonal therapy that we were giving to the patients. Now, it turns out that while we were trying to attenuate the bad neurohormones, Mother Nature also had good neurohormones to try to bring a balance between the good and the bad. These are vasoactive peptides, natriuretic peptides, the levels of which go up. So we know that patients with heart failure have higher BNP levels, and higher BNP levels are associated with poor prognosis, not because BNP is leading to poor prognosis, but because it's a marker that you need counter-regulatory biomarkers to attenuate the effect of adverse neurohormonal activation. So the higher the level of BNP, the higher the adverse neurohormonal activation as well. So once we sort of understood this pathophysiology, we thought that maybe what we ought to do is not only focus on one side of the ledger to try to attenuate the bad neurohormones, but how about if we try to accentuate the good neurohormones as well and try to bring a balance. So these neurohormones, the good vasoactive neurohormones like BNP, they are metabolized by an enzyme called neprilysin. So the question is, can you block that enzyme neprilysin and lead to an increase in natriuretic peptides to try to bring out the balance? That was tested in this trial called Paradigm HF trial. And in this trial, valsartan sacubitril was compared to enalapril head-to-head to see whether there are any beneficial effects. Now, a few points I want to quickly mention here. One is that you don't see a word on this slide, which you have seen in almost all other clinical trials, and that is the word placebo. This is not a placebo-controlled trial. This is basically you're taking a standard of care and you're saying that we will now be replacing, if this drug works better, with a new foundational standard of care. So in order to do that, you have to compare it against the standard of care, and the standard of care is enalapril 10 BID. That was the dose and the drug used in SOLVE trial and consensus trials and the trials that led to the use of ACE inhibitors in patients with heart failure. So what did we find in this trial? Again, please keep that in mind, that this is not placebo control against really high dose, very good baseline therapy. With the use of valsartan sacubitril, there was an impressive further 20% relative risk reduction in the primary endpoint of cardiovascular death and heart failure hospitalization, a number needed to treat of only 21. And then no matter how you slice and dice the primary endpoint, you look at cardiovascular death by itself, heart failure hospitalization by itself, the combination of the two, or cardiovascular death, there was substantial benefit that was seen when patients were given valsartan sacubitril. What about when it is given to patients in the hospital setting? So the trial Paradigm HF, very large trial, largest trial ever done in heart failure, over 8,400 patients were enrolled. That was in the outpatient setting. What about in the hospital setting? So this has to be a short-term trial, 8-week trial. Biomarkers was the primary endpoint. Pioneer HF, again with valsartan, sacubitril versus enalapril. And as you can see, there was a robust, only in 8 weeks. I mean, this is literally a 8-week study, and you can see that there was a 42% relative risk reduction in the clinical event rate. Recurrent hospitalization also went down by about 44% relative risk reduction. Is there any impact on reverse cardiac remodeling? So this was a single-arm pre-post study, about 800 patient PROVE-HF. New use of valsartan sacubitril led to about 5% improvement in ejection fraction at 6 months and about 9.4% improvement in ejection fraction at about 1 year. You can also see significant reductions in LV end diastolic and systolic volumes by about 12 to 15 ml as well. And what about the quality of life score? So we all know that about a 5-point improvement in Kansas City cardiomyopathy questionnaire improvement leads to a substantial patient subjectively feeling better as well. And the new use of valsartan sacubitril led to a progressive increase in quality of life that went all the way up to in the 9 range. So that led to valsartan sacubitril becoming the foundational therapy for heart failure, and the guidelines recommended that as a first-line therapy in patients with ACE inhibitors to be switched. Now, a lot of the patients are unable to tolerate beta blockers at maximum doses, and heart rate is associated with poor outcomes in patients with heart failure. So that was tested in this trial called the SHIFT trial with ivabradine. And the bottom line is that by giving ivabradine to patients with heart failure and a heart rate over 70, there was a substantial reduction in the combined endpoint of cardiovascular death and heart failure hospitalization, about an 18% reduction. So to just keep a few points in mind about the SHIFT study, and that is, it was ejection fraction less than 35%, not 40%. It was a normal sinus rhythm. We don't give this drug for patients with atrial fibrillation, and this is not a replacement for beta blocker. This is on maximum beta blocker, and if the heart rate is high, then you can give this. Cardiovascular mortality, unlike valsartan sacubitril itself, did not improve. The improvement was in the composite endpoint, which was primarily driven by heart failure hospitalization. So then the guidelines were updated as compared to the one that I showed earlier. And basically, it is up to you whether new onset heart failure, you want to start on ACE-ARB or ARNI, which is valsartan sacubitril. But once somebody is on valsartan sacubitril, there's a once somebody is on ACE inhibitor or ARB, there's a class 1 recommendation that all of those patients, class 2, class 3, should be switched to valsartan sacubitril. So sort of the new standard of care is valsartan sacubitril, aldosterone antagonist if the potassium and creatinine is okay, and the use of beta blockers. Ivabradine did not get a class 1 indication, but got a class 2 indication because there was no mortality benefit per se. Now, we all know that there's a common link between diabetes and chronic heart failure. One begets another because of the common pathophysiology. And in the diabetes cardiovascular outcomes trial, which were not heart failure trial, we saw a lot of heart failure-related benefit across the class from empagliflozin, dapagliflozin, and canagliflozin in these patients, which led to a hypothesis that maybe these drugs could be used for treatment of heart failure. Moreover, in the interest of time, I won't be able to go into the details of this slide, and maybe in the Q&A we can talk about this, but there are so many pharmacodynamic effects of these drugs on the heart, on the kidney, on the metabolism, on adiposity, on inflammation and oxidative stress, on ATP production, on autophagy, so on and so forth, that the hypothesis even further extended that not only is it may be useful for the management of heart failure, but what does any of this have to do with diabetes? That maybe these are just cardiovascular drugs that can manage patients with heart failure even in the absence of diabetes. So Dr. Solomon and Dr. McMurray led this a really innovative study of taking a diabetes medication and using it in patients even without diabetes. So this trial, DAPA-HF, basically was agnostic of whether or not you have diabetes. All heart failure with reduced ejection fraction patients, less than 40%, were randomized on standard of care with dapagliflozin or placebo. In the interest of time, again, won't go into the detail, but pretty standard heart failure with reduced ejection fraction population. But what is to be noticed is that less than half of the patients have diabetes. 55% of the patients did not have diabetes. And this trial literally enrolled the best possible baseline therapy that I've ever seen in any other trial. We're living in this phase of polypharmacy, so we ought to make sure that whatever drug we are adding it has incremental benefit over standard of care. So as you can see, diuretic use more than 90%, RAS inhibitor use more than 90%, beta blocker use more than 90%. And MRA use, which in clinical practice has ranged in the 30-40% range. Most patients, it will never be 100% because of the creatinine and the potassium issues, but I've again not seen a trial where MRA use has exceeded 70%. So really well-treated group of patients. So let me mention a couple of points before I talk about the results of DAPA-HF. Look at the placebo control. I mean, this is as good as a patient will be treated. 70% were class 2, and these were outpatient. Look at 1 year of event rate in the placebo. About 1 in 6, 7 patients ended up reaching the endpoint. 2, look how quickly the curves separate. And the bottom line is that on top of this very good standard of care, there was a 26% relative risk reduction with the use of dapagliflozin, an absolute risk reduction of about 4.9%, and number needed to treat of only 21. I want to highlight on this point is that I am really, really guilty in my own clinical practice that if I'm busy and somebody is class 2 and they're kind of sort of doing okay, so you just say, you know what, why don't I just change your medication the next time I see you in 3 to 6 months? Look at this. I mean, at 28 days, there was a statistically significant difference. I mean, these changes occur relatively fast. So not only do we need to be treating our patients appropriately, but the quicker we treat them, the more benefit we can give them. Now, this is sort of the money slide. This is the, there are incremental progress in medicine, and then there are just sort of exponential changes. So this slide represents that. And that is the only difference between diabetes and no diabetes is the absolute event rate. But these two curves are almost interchangeable. So no difference in those with or without diabetes. Both groups benefited, which proved the hypothesis that these drugs are good for cardiovascular risk modulation. You can slice and dice the data whichever way you want to, no difference. Every single subgroup benefited with the use of dapagliflozin as opposed to not giving dapagliflozin. And then lastly, we have been, so I practice in Mississippi and we are a poor state, so cost is really an issue, and I'm very cognizant of the cost issues. But I'm talking about here from a pathophysiologic perspective. If patients cannot get all of these medications for social reasons, that's a real issue that we need to deal with. That from a pathophysiologic issue, the question that is frequently asked is that we had all generic medications, ACE inhibitors, beta blockers, MRA, and now we have 2 trade medications, valsartan, sacubitril, and dapagliflozin. What do you use? So the bottom line is that in this trial, if for some reason your patient cannot be on valsartan, sacubitril, you benefited with the use of dapagliflozin. And if a person could be on valsartan, sacubitril, not only did you benefit exactly the same. In other words, these are parallel pathways, and on the basis of that, modulation of all of these pathways will improve outcomes. So the treatment, the best possible patient treatment, is to give a combination of all of these therapies. And again, both heart failure and cardiovascular death was improved. So the last trial I'll mention very briefly is that all of these trials that I showed you enroll patients in the outpatient setting. There is this emerging concept of worsening heart failure. These are the patients who on standard therapy are requiring either hospitalization or IV diuretics in the outpatient setting. So there is another drug called vericiguat, which was a cyclic GMP. Worked on a cyclic GMP. It's a soluble guanylate cyclase. a stimulator and improves downstream signaling. This drug was tested in this trial called Victoria trial, where vericiguat was compared to placebo in worsening heart failure patients. And the bottom line is that there was a 10% relative risk reduction in the combined endpoint of cardiovascular death, heart failure, hospitalization. Of note here is that the 1-year event rate is greater than 30%, almost 3 times what we have seen in chronic heart failure trials. So while it's only a 10% relative risk reduction, the absolute risk reduction was about 4% comparable to the other trials. Dr. Solomon published this paper, again, highlighting the fact that we cannot really pick and choose the medication. The best option is to give all the therapies together. And if you were to use all 4 therapies in combination, you are looking at an excess of 8 years of life. I mean, this is not some therapies that we give and we get a few extra months. We're talking about 8 years of life if you're 55. And even in octogenarians, there is a greater than 1 year survival benefit that you get. So this is my last slide. A colleague of mine, Dr. Carolyn Lamb, and I sort of put this together, will be coming out soon, which is basically highlighting that now we know 5 pathways: angiotensin 2, norepinephrine, aldosterone, neprilysin, and SGLT receptor, the modulation of which with 4 drugs, valsartan, sacubitril, evidence-based beta blockers, MRAs, and SGLT2 inhibitor dapagliflozin, leads to substantial improvement in outcome. And in some niche populations, persistent high heart rate, ivabradine, self-identified Black patients, hydralazine nitrate, and worsening heart failure, vericiguat can be considered. Lots of data to be presented. Sorry for the speed with which I get, but I'll be happy to answer any questions. And I again appreciate the opportunity to be giving this presentation.
Thank you, Javed, very much for this wonderful talk. I will start the questions, please, and then we take that for the panelists and the audience. From this paradigm and the other results, Pioneer and Prove It, is it allowed for us to start ARNI as a starting point, not the patient is not responding to ACE or ARBs, and then we go to ARNI? And the second question regarding this speculation, there is a decrease of sudden death in paradigm heart failure. So what do you think in spite there is no CRT, ICD on these patients? What's the mechanism of this?
Yeah, so the answer to the first question, when the guidelines were being written, Pioneer HF was not out. Pioneer HF came out after that. And because it was an acute heart failure population, it turns out that over a third of the patient had de novo heart failure, new onset heart failure, and over 50% of the patients were not on an ACE inhibitor or ARB. So they were basically de novo initiation of angiotensin receptor neprilysin inhibitor. And the primary endpoint basically was no different. You got benefit whether you had de novo heart failure or chronic heart failure, and whether you had you were on ACE or ARB, or whether you were not on ACE or ARB. So I don't know how Dr. Bhaskar or Dr. Solomon or one of the other colleagues from Egypt feel about this. At least my perspective is that it's the same disease, it's the same pathophysiology. I see no rational reason to start an ACE inhibitor and give an inferior drug for 4 to 6 weeks and then switch it to an ARNI, as opposed to starting from ARNI, especially considering the fact that the curves separate pretty soon. In terms of the sudden cardiac death, yes, there was a substantial sudden cardiac death benefit seen in with the use of valsartan sacubitril. What is interesting is that patients who did not have defibrillator had a higher risk of sudden cardiac death, as you might expect, as those patients who had a defibrillator. But there was a significant benefit, a relative significant benefit with valsartan sacubitril, regardless whether you had a defibrillator or you did not have a defibrillator. In other words, a defibrillator does not mean don't give valsartan sacubitril. The use of valsartan sacubitril does not mean don't give a defibrillator. Again, parallel pathways. And you know, I'm sort of a heart failure doctor, so we sometimes sort of forget what our arrhythmia colleagues are saying. But the American College of Cardiology, American Heart Association, and Heart Rhythm Society, in their guidelines, actually have given valsartan sacubitril a class 1 recommendation for certain cardiac death prevention in heart failure patients.
Okay.
I have a question.
Mahmoud,
Yes,
yeah.
sir.
Yes, Dr. Butter, thank you for this great presentation. Well, I found that the number needed to treat was 21. It was identical in the paradigm trial and the DAPA-HF. Is it surprising for me? Is it just a coincidence? And another question about the use of sodium glucose transport inhibitors in non-diabetic patients with heart failure and reduced ejection fraction. Is there a cutoff value of GFR below which I should not use those agents?
Yeah. So the number needed to treat of 21, I mean, that actually is a coincidence, but I think number needed to treat, we sometimes sort of misinterpret, because the number needed to treat really depends on the duration of the trial, and different trials that have run for different duration can affect the number needed to treat. So I would probably just basically focus on the primary endpoint and relative risk reduction. But yes, it just happened to be a coincidence. In terms of the GFR, it's an interesting question, because you sort of live and learn, right? So when new drugs come up, you don't know how to use them. I mean, I remember I was a cardiology fellow when beta blocker trials were being done, and we were giving sort of low dose and keep having people sit in the clinic for an hour and all that kind of stuff. And now we start and titrate them on a telephone. So you sort of learn. So when the SGLT2 inhibitor trials were coming out, we really didn't know initially how to use them, and they do cause osmotic diuresis and natriuresis. So because of that, there is an initial change in the GFR. So there was this sort of stigma related to the creatinine. Also, your glucosuric effect, not cardiovascular benefit, but glucosuric effect relates to how much your baseline GFR is and how much glucose are you filtering in the first place. So the original recommendation was to not use for GFR less than 45 for glycemic control. The heart failure trial went to the GFR of 30. And now chronic kidney disease trials are coming out, and we will learn a lot more about it.
Okay.
David, thank you very much for your elegant presentation. I have two questions. First question related to the reduction of NT-proBNP and the favorable impact of sacubitril valsartan on parameters of LV remodeling. If small doses of sacubitril valsartan could achieve this favorable effect, reduction in NT-proBNP translated into a favorable impact on LV remodeling, because usually in the daily practice, sometimes we couldn't achieve the target doses, and the target doses is the doses which has a beneficial effect in patients with heart failure. The second question related to the use of diuretics in patients in the DAPA-HF or in the Victoria study. I know that there is sub-analysis regarding whatever the dose of diuretics used, the benefit was there. So can you elaborate on these 2 points?
Yeah, so both are excellent questions, but I want to highlight before I give the answer that this is just my opinion. This is not sort of evidence-based. So, when I round with the residents or the medical students, I sort of tell them that, if you have $100, what would you rather do? Sort of have a great meal or drink something, or, put gas in your car, or do you use a little bit, $20 for gas and $20 for food and $20 for drink? And it's just better to do a little bit of everything, not a lot of one and nothing of other. My personal bias is we don't have dose ranging data with valsartan sacubitril, but we do have dose ranging data with beta blockers, with ACE inhibitors, and with ARB, that you get a lot of benefit at low doses, but it's a good idea to give high doses for more benefit. But the best benefit you get is when you start the therapy to begin with. So if you have borderline blood pressure, borderline creatinine, borderline potassium, it is better, in my opinion, to give low doses of all the 4 agents than high doses of one and unable to give some other drugs. So my bias will be to give low doses of valsartan sacubitril, beta blocker, MRA, and then dapagliflozin, and then go up based on blood pressure and creatinine. And my bias, again, will be that I will first go up on beta blockers before I go up on something else. So that's the blood pressure question. And then the second question was what, sorry?
Related to the diuretics in DAPA-HF.
Yeah, it's sort of interesting. I would have thought that valsartan, sacubitril, you sort of pee, and then dapagliflozin, you do the same thing. And although the MRA dose we use is not high enough, but nevertheless you maybe could. But the DAPA-HF secondary analysis on the diuretic doses was just recently last week presented, and it turns out that most of the patients did not require much of a change in the diuretic dose at all. So I don't think that there is a formula that we can give. But again, if you have an older patient who has a low blood pressure to begin with, I would be a little bit more cognizant and maybe modulate. But most patients should be able to tolerate it. You don't need to change the diuretic dose a lot.
Sorry, do you have any comments?
Pardon me?
Can I make a comment about that? Javed, on the DAPA-HF, about 11% was on the background ARNI therapy with sacubitril valsartan. So maybe as we gain more experience for the combo with SGLT2 inhibition along with ARNI, there may need to be a little bit more concern about preemptive reduction in diuretic dose. We know that in ARNI, because in most of the ARNI trials, the diuretic dose compared to either the ACE or the ARB arm was lesser. And now with the SGLT2, we know there is volume loss, weight loss. And yes, there is the adverse outcome of potential hypotension and or volume contraction with especially extreme cases. So maybe when the combo happens, there may need to be a little bit more caution about reduction in the background diuretic doses, at least to follow the patient closely.
There is a question from the audience about trimetazidine in heart failure. Do you have an idea about this? Trimetazidine. This is a European drug.
Yeah.
Using chronic stable angina and prove some way in heart failure. What do you think, Dr. Javid?
I mean, I have zero experience with this. There are some data from Europe and from China talking about exercise capacity improvement and people feeling better. But I literally have zero experience with this drug.
Bickman and Scott?
No,
okay.
No experience with that drug.
So I want to ask you about what's known as the quality of life. The patient usually in 1 week or 2 weeks, when you take an ARNI, improve that my life has been changed. Is it true? Because most of the drugs, not in heart failure, for example, improve the symptom, but he didn't. The patient did that. I'm changing my life now. Why? Well, is anything apart from just treating the heart failure to improve quality of life, or we don't have tests for quality of life for other drugs? What do you think?
Yeah, I mean, that's a difficult question to answer because, I sort of almost wonder whether some of those responses we generate from the patient because we tell them that, we are about to start on a great drug and you're going to feel great, and then they come back and then they feel sort of great. I can tell you that Paradigm-HF is not the good trial to look at the KCCQ score, because if you look at most heart failure therapies, if it's a beneficial therapy, the biomarker and quality of life scores get better fast, and then remodeling and mortality and whatnot takes some time. Well, the problem with Paradigm-HF is that there was a 6 to 8 week run-in phase with high-dose ACE inhibitor and valsartan sacubitril, so their so-called baseline already had been very well treated. If you look at other studies like PROVE-HF or the CHAMP registry, now the problem is that these are sort of single-arm trials. You're looking at 5 to 10 point improvement in KCCQ, which would actually correlate with patients feeling substantially better. So yes, my experience is the same, that there are many people who feel better, but I am also a little bit shy to make too many claims because it is what it is.
Well, I'll add, if I could, to what Javed just said. There is one randomized trial, the Evaluate trial, that compared patients similar to Paradigm, comparing sacubitril valsartan to enalapril, and did see about a 4 to 5 point difference between the two groups in pretty much every domain of the Kansas City Cardiomyopathy Questionnaire. So I think you're absolutely right that patients do feel better in a relatively short period of time of that drug.
And one of the hypotheses, and I know there could be quite a few, in addition to the cardiohemodynamic effects, is the neprilysin, which is the endopeptidase, actually affects a variety of other neurohormones beyond the cardiovascular domain. And there had been actually evidence from neurology and other fields that it also breaks down enkephalin, and it actually used to be called enkephalinase. So it.
Yes.
And now there is the concept of whether the endorphins or enkephalins, which are the substrates that counteract the pain perception and so forth, are also impacted. But this is just hypothetical. We don't have large-scale data. There have been some former neurology studies implying the beneficial effects. And I think interdisciplinary data and/or collaboration will help us. And we will need to be able to go back and look at the plasma samples of treated patients.
Okay.
But the early difference is quite striking, and I think implies potentially other effects beyond the hemodynamic and/or cardio effects.
Yeah. Okay. Thank you
Dr.
very
Solomon, will we be seeing a depression trial with valsartan sacubitril?
There has been pain trials, and it actually has been used in many other specialties before cardiology, starting with nephrology in 1970s, then neurology for the pain perception through the 1990s, and then through oncology because they use it as a biomarker for ALL. And it's got nothing to do with cancer, it's a biomarker, but neprolizin is an interesting endopeptidase. And thus, we need to go back and look at the science of whether what other specialties have done. Yeah, we're targeting it or interpreting the beneficial effects for prevention of breakdown of natriuretic peptides, but also GI effects are quite wide, glucagon and so forth. So the interplay with the metabolic axis is going to be very interesting. We know that it does provide glucose control too.
Yeah.
So the hemoglobin A1C goes down, and so the interaction with the SGLT2 inhibitors are going to be very interesting to find out.
Regarding the ejection fraction and the symptom relief, some patients, most of the patients, the ejection fraction improved a little bit. We don't do cardiac remodeling, cardiac MRI for the patients. We do elliptical. We can do ejection fraction not by M mode, by 2D, but the patient improved significantly out of proportion ejection fraction. As Magdi said about the biomarkers, is there any parameters, objective parameters, like the imaging and biomarker like PNP, to say that this patient improved for all of the patient, or just depending on the symptoms of the patient?
Well,
go ahead.
No, happy to answer that if I can. So we did for 5 years after we presented Paradigm, people kept saying, what is the effect of this drug on the heart? And I couldn't answer that question because we hadn't done a study to assess the effect on cardiac structure and function until we did the PROVE and EVALUATE trials. PROVE was a study of single arm for a year of patients who were being put on sacubitril valsartan. So it was not randomized. EVALUATE was randomized for only 12 weeks. But in both studies, we saw improvement in measures of cardiac remodeling and ejection fraction. Remodeling improved in the EVALUATE trial in only 12 weeks, surprisingly. In a year, we saw a pretty substantial, over 10-point increase in ejection fraction in the PROVE study. We have to discount some of that because it was a open label, single arm study. So I think we really do believe now that there is truly a hemodynamic effect and an effect on the heart itself. It's not just that the patients are feeling better, and this is almost certainly responsible, or at least responsible in part, for the great outcomes benefits that we saw in Paradigm.
Thank you very much. And go, Dr. Mahmoud, can you use second? Thank you, Dr. Jabir.
Okay. I'm privileged to introduce Dr. Scott Solomon, who is the professor of medicine at Harvard Medical School, Brigham and Women's Hospital, Boston, Massachusetts. Dr. Solomon, I think, is the best one to speak about heart failure with preserved ejection fraction. He was the principal investigator in the famous Paragon trial. So please, Dr. Solomon, go ahead.
Well, thank you very much for that kind introduction. And obviously, it's a real pleasure to be on this webinar. And I'm really sorry that I couldn't be there in person to be with you directly. But it's an honor to share this podium with all the distinguished members of the faculty. Here are my disclosures. Let me just take a step back for a second, because it was not really that long ago when we didn't talk about heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. We talked about heart failure. Heart failure is a clinical syndrome, and it's a clinical syndrome that we can define, I think is a good definition, the inability to provide adequate cardiac output to the body at rest or with exertion, or to do so only in the setting of elevated filling pressures. That definition covers heart failure regardless of the ejection fraction is high or low. And we know that to be a clinical syndrome characterized by breathlessness, fatigue, and edema caused by an abnormality of the heart. I say caused by an abnormality of the heart because, as we all know, there are many other things that cause breathlessness, fatigue, and edema. And it was only about 25 years ago that we recognized that there was this entity of heart failure with relatively preserved systolic function. We used to think it was all about the pump. And in fact, we now know that there are patients who have the syndrome of heart failure whose ejection fraction is normal, near normal, or mildly reduced, but certainly not in the range of the patients that Dr. Butler was talking about a few minutes ago. So there are two phases of heart failure. The guy on the left comes into the emergency room and has a dysfunctional left ventricle with a reduced ejection fraction. You will have no trouble understanding what is happening with that patient. But the person on the right can have the exact same signs and symptoms as the person on the left. And yet when you do an echocardiogram, that ejection fraction looks pretty much normal. And you would have a hard time looking at that heart and saying that patient has heart failure. Well, obviously, the person on the right has heart failure with preserved ejection fraction. Now, depending on how you define preserved, and we'll talk about that, and depending on what registry or cohort you look at, about 30 to 50% of all patients who come into the hospital with heart failure indeed have preserved ejection fraction. Those patients, turns out, have virtually the same signs and symptoms as patients with heart failure with reduced ejection fraction. And these are data from the CHARM study, which was a study of heart failure across the spectrum of ejection fraction. Patients with HFpEF have edema, they have orthopnea, they have PND, they have rest dyspnea, they have crackles, they have an elevated jugular venous pressure. The only signs they don't have are the S3 gallop and cardiomegaly, to the extent that patients with heart failure with reduced ejection fraction do. Now, HFpEF, as I'll call it, is increasing in prevalence. These are data from my own country, but it's true around the world. It's particularly increasing in women and also in my country in African Americans. There are many people who have argued that it really isn't a disease. It's just a collection of comorbidities, because we've seen that patients with heart failure with preserved ejection fraction tend to be older. They have more hypertension, they have more atrial fibrillation, they have more COPD, they're more anemic. So maybe there isn't a disease. Maybe it's just a collection of these comorbidities. I don't think that's the case. And the reason is that if you look at the event rates for either mortality or heart failure hospitalization in patients who don't have heart failure but have all those other comorbidities in trials like Europa and Peace and Life and Hope and Value, trials of hypertension and diabetes and coronary disease, their event rates are so much lower than if you look in iPreserve and CHARM, where patients had this entity that we call heart failure. So what do we mean by preserved? This is a tricky question. I don't really know the answer to that question. I can tell you that we defined reduced ejection fraction about 20 years ago as everything in the lower range of 40% or under. And that was really based on the trials that had been done in patients with heart failure. The SOLVE trial, the ROUSE trial, the VALHEF trial, all set specific cutoffs. And so when we showed that ACE inhibitors were beneficial, that MRAs were beneficial, that angiotensin receptor blockers were beneficial, that beta blockers were beneficial, it was primarily in patients who had been defined as having heart failure with an ejection fraction that was 40% or below. And that's why historically, that's what we call heart failure with reduced ejection fraction. When we did the CHARM trial, we defined a new entity, heart failure with preserved ejection fraction, simply to say, what are all these other people? We all know that it isn't because their ejection fractions were normal. We don't have normal until you get up into the 55% and higher range. So there's been some debate about what we use to describe this entity and what cutoff we use. And in fact, it got even more complicated over the last few years because the ESC created a whole new category. Okay, maybe I should take some of the blame for that because my colleague Carolyn Lamb and I introduced this concept in 2014, the middle child in heart failure with mid-range ejection fraction. I don't think we really ever wanted another category. We wanted to draw attention to this group of patients in whom we really hadn't paid much attention to in this middle range between frankly reduced and closer to normal. I'm going to come back to that in a few minutes. Now, the other thing that we used to think about heart failure preserved ejection fraction was that it was all about diastole. Remember, diastole is the relationship. It's all about the relationship between volume and pressure in the heart. And I like to show this illustration when I'm teaching the medical students. It'd be very easy for any of us to blow up an inner tube with our mouth, but not if that inner tube is on a car, because it's under so much more load. So it would take a degree of pressure that our lungs simply can't generate. And so a patient who has diastolic dysfunction, their pressure volume curve is such that it takes more pressure to get to a certain volume. The curve is shifted upwards and to the left. That's what we used to think was the primary problem with heart failure with preserved ejection fraction. We used to call it diastolic heart failure, in fact. The problem is that if you look at elderly individuals who are normal, even those who are the healthiest elderly group without diabetes, without hypertension, without heart failure, without coronary disease, they have diastolic dysfunction. Diastolic function gets worse normally as we age. And so it can't really account for why these people get heart failure. Now, people with HFpEF certainly have more diastolic dysfunction than those who don't. But we don't believe that alone can account for it. We've gone back to looking at systole. In fact, if we look at patients with HFpEF in clinical trials, and we use some more sophisticated measures to look at cardiac contractile function other than ejection fraction, like myocardial strain, we see that strain is actually reduced, both longitudinal strain and circumferential strain in patients with heart failure with preserved ejection fraction. We've shown this in Paramount, we've shown this in TopCat, we've now shown this in another trial that I'll be talking about in a few minutes. Not anywhere near as bad as patients with heart failure with reduced ejection fraction, but clearly not normal. So it's a bit of a myth that we understand the etiology of HFpEF. There are many molecular mechanisms that have been postulated: dysfunctional calcium handling, abnormalities in the spring-like titin protein, that is the longest protein in the body and is responsible for restoring the sarcomere to its resting length. We know that diseases like hypertension and diabetes cause increased extracellular fibrosis. This reduces the ventricular compliance relationship and shifts the pressure volume relationship that I showed you before. The concept du jour is that inflammatory diseases driven by comorbidities like obesity, type 2 diabetes, and hypertension may lead to systemic inflammation, which leads to a generation of reactive oxygen species reducing available nitric oxide. This causes a reduction in cyclic GMP, a reduction in phosphokinase G, which stimulates myocyte hypertrophy and stiffness. It's a very nice theory, and I can't tell you that we have a profound amount of evidence really supporting this just yet. With respect to therapy, we've been between a rock and a hard place. If you look at the most recent clinical practice guidelines from the New England Journal of Medicine, written by Maggie Redfield, she says, consider alternative diagnoses, treat symptomatically with diuretics, treat for hypertension, treat other comorbidities, rate control and atrial fibrillation. We don't even necessarily know that maintenance of sinus rhythm is beneficial, although many of us believe it is. Diagnose and treat ischemia, and if all else fails, consider potentially spironolactone. And I'm going to show you why I mentioned that in a second. Now, here are the prior 4 outcomes trials done in HFpEF, Charm Preserve, PEP-CHF, iPreserve, TopCat, and as you can see, none of them made their primary endpoint. The one that probably came closest is TopCat. And TopCat, as you know, was a NIH trial comparing spironolactone or placebo. And when we unblinded this study, we saw something that was really quite disturbing, which is there are 2 different populations of patients. The patients who were enrolled in the United States, Canada, Argentina, and Brazil had a very high event rate. And they also had a pretty significant treatment effect of spironolactone. However, the patients who were enrolled in Russia and the Republic of Georgia had a very low event rate, and they didn't have a what appeared to be a treatment benefit. In retrospect, I think we believe that these patients most likely didn't have the syndrome of heart failure. We could talk about this for an hour, but I think it makes many of us believe that the therapy may have been beneficial had it been done in a larger group of patients with, in fact, heart failure. Well, I'm going to tell you more about sacubitril/valsartan that Dr. Butler introduced. And of course, he already told you what this drug was, how it works. It's a drug that contains both valsartan, the AT1 receptor blocker, and sacubitril, which is the neprilysin inhibition. And as he mentioned, neprilysin is an enzyme that breaks down the biologically active natriuretic peptides, including ANP, BNP, and CNP, and a whole lot of other vasoactive substances as well. And Dr. Boskert mentioned just a few of them. And so it simultaneously blocks the renin-angiotensin system and raises levels of the vasoactive peptides that we think are endogenously protecting us in the setting of heart failure. So when we did Paradigm, we were also doing a pilot study in HFpEF called Paramount, in which we showed in 300 patients that we could reduce NT-proBNP, improve left atrial size, and improve New York Heart Association class in patients with heart failure, preserved ejection fraction. This was a phase 2 trial. Still, I believe the only positive phase 2 trial, at least pharmacologic trial in HFpEF. And it was on the basis of that study that we went ahead and designed the Paragon HF study. Paragon was a active comparator trial comparing sacubitril/valsartan to valsartan. We enrolled patients with heart failure, preserved ejection fraction, who had evidence of structural heart disease. So we wanted to make sure it was a disease of the heart. They had to have elevation in natriuretic peptides. They were also, just like in Paradigm, entered into a sequential run-in period and then randomized to sacubitril or valsartan or valsartan. We enrolled roughly 4,800 patients, and the primary endpoint of the study was a composite of total, which included first and recurrent heart failure hospitalizations and cardiovascular death. So I presented these results at the ESC last year. And when I showed this slide, there were lots of oohs and ahs, because you can see that these do separate. There's a lower event rate in the patients receiving sacubitril/valsartan than valsartan, 12.8 versus 14.6. The rate ratio is 0.87, and the confidence interval just crosses 1 with a p-value of 0.059. So this was met with lots of oohs and ahs in the audience in Paris that day. And I can tell you that It's not a number that you want to see when you're unveiling a clinical trial. But clearly, we believe there's a biologic effect here. And if we look at the effect on heart failure hospitalizations, it was reduced by 15%, again, against an active comparator, valsartan. Cardiovascular death was not affected at all. So this result was predominantly or almost exclusively driven by heart failure hospitalizations. When we look at our secondary endpoints, we see improvement, significant improvement in New York Heart Association class, improved by 45%. We see evidence of improvement for KCCQ. If we look at a responder analysis, we see a 30% improvement. When we look at the mean improvement, it was about a 1 point that just barely missed statistical significance. Interestingly, patients had a very remarkable improvement in the composite renal outcome, which was a composite of renal death, reaching end-stage renal disease, or a 50% or greater decline in GFR. There was a 50% reduction in patients arriving at or reaching that renal outcome. There was no effect whatsoever on all-cause mortality. Now, things got interesting when we start to look at subgroups. Most of the subgroups look very similar, regardless of which subgroup they were in for sacubitril valsartan versus valsartan, with the exception of two, sex and left ventricular ejection fraction. We actually saw a greater treatment benefit for women than in men, and this was highly statistically significant, even with multivariable adjustment. And the same thing was true for patients with an ejection fraction below our median of 57%. And these were both pre-specified subgroups. So we see that the patients who have lower end of ejection fraction derive greater benefit. Let me show you that in a little more detail, because here we can see in quartiles that patients have a benefit that is really quite very much similar to what we saw in Paradigm, and I'll show you that in a second, until they got to the sort of mid-range of ejection fraction, and then it started trending upwards, and then the benefit seemed to go away when you get to the high ejection fraction. So we were able to take now the data from both Paradigm and Paragon, put them together in a pre-specified analysis, and when we do that, it shows you an important lesson, is that it's always good to do big trials. If we could have done this as one giant trial, we would have seen significant reductions in every single endpoint, including all-cause mortality. But we would have also seen this curious interaction with ejection fraction, in that we see benefit in the combined group in ejection fraction all the way until you get to about 60%, and then we don't see much at all. So the benefit in Paragon and Paradigm were actually quite similar all the way through ejection fraction that I would call pretty close to normal. Here's what it looks like continuously with ejection fraction on the x-axis and the rate ratio, essentially the hazard ratio on the y-axis, and we see that it trends upwards. It gets even more interesting if we break this down into men and women, because the trends are the same. You get a reduction in benefit as ejection fraction goes up, but women derive benefit to a greater ejection fraction than men, all the way up through that spectrum. And so what have we learned here? HFrEF, we believe, is etiologically heterogeneous. There are lots of things that cause it: ischemic disease, genetics, viral diseases, electrical diseases. It's phenotypically heterogeneous, we know that, and it's therapeutically homogeneous. Most of the drugs that we use for HFrEF treat patients and benefit patients regardless of their etiology. HFpEF, I think, is etiologically heterogeneous, phenotypically heterogeneous, and probably also therapeutically heterogeneous, in that perhaps there isn't one size that fits all. Let me go back to the mid-range of heart failure, because here we've learned some lessons. We've published data previously from both the CHARM trial and the TOPCAT trial that if you see any benefit in these studies, it's in the patients in the lower range of ejection fraction. That range between 40 and say 55%. Those patients in CHARM with candesartan and TOPCAT with spironolactone seem to benefit the greatest. Well, guess what? It looks exactly the same if we look at Paradigm and Paragon. So if we had been treating more of our patients below normal as if they had reduced ejection fraction over the past 20 years, we might have saved a lot more patients. We might have improved the health of a lot more patients. And I think we really need to rethink what is heart failure with reduced ejection fraction. Should we call mid-range mildly reduced? How do we define HFrEF as below normal? We might be treating a lot more patients with ACE inhibitors, beta blockers, MRAs, and ARNIs than we did subsequently. Lastly, I'll just tell you about a few other trials that are ongoing in this field. Javed Butler mentioned the SGLT2 inhibitors. There are two that are currently heading towards completion with SGLT2 inhibitors, the Emperor Preserve trial that Javed is leading with empagliflozin and the Deliver trial that I'm leading with dapagliflozin. In addition, there are other approaches that are non-pharmacologic based, such as a shunt that goes between the left and the right atrium and serves to decompress the left atrium. There's an active trial going on with those as well. And then the most recent addition to the trial list is a new study that was just announced actually in the last 2 days called Fine Arts that will be using a non-steroidal mineralocorticoid receptor antagonist, finerenone, and randomizing patients with heart failure with preserved ejection fraction. And that's, of course, basing on the potential benefit that we think we saw in the TOPCAT trial. So at the end of the day, we don't necessarily need evidence-based evidence for everything we do in medicine, but when we can get evidence, we certainly like to utilize it. We're doing our best to generate the evidence in heart failure with preserved ejection fraction. And until we have all of that evidence in, we are flying a little bit by the seat of our pants. Thank you very much for your attention.
Thank you, Professor Solomon, for this great presentation. I have a few questions. First, about heart failure with mid-range ejection fraction, the middle child or the illegal child, as you have once called. Can we forecast in the next guidelines, heart failure guidelines, that this artificial entity would be eliminated? I know it's a tough question, but what are your predictions?
It's an especially tough question because I certainly, I'm not part of the guidelines in either side of the Atlantic, and I wouldn't want to guess the way they're thinking. But I do think that we've learned a lot about people in this range over the past 4 or 5 years. We've paid more attention to it. There are hundreds and hundreds of papers that look at this group. I don't really, I believe it's a concept, not a specific range, because ranges are arbitrary. 40% was arbitrary, 50% is arbitrary. And so the idea that we can, that a patient with an EF of 39% is different from a patient with an EF of 41% is ridiculous. Just like a patient with 49 and 51 are no different. But in concept, I think this tells us that most of the patients, and we have really good evidence for this now, in the lower range of HFpEF, with ejection fraction below normal, have systolic dysfunction, and they seem to benefit from drugs that we've shown over and over again benefit patients with systolic dysfunction.
Dr.
Okay,
Scott.
another question. Can we set new cutoff values for ejection fraction according to sex? I mean, patients with heart failure, do we need different cutoff values for our levels of ejection fraction according to gender? And the second question, were there sex differences in the Paragon trial? I mean, women did benefit more than men. Was it related to the ejection fraction or some other factor other than just sex, being a man or a woman?
These are great questions. Well, first of all, I have to say that I think we've not done enough to just understand the biologic differences in terms of the heart failure syndrome in men and women, how different drugs might affect men and women. This is something that we have to do. In Paragon, I was very proud of the fact that we enrolled as many women as in any heart failure trial that had ever been done. 52% more women than were all in all of the SOLVE trial enrolled in Paragon. So we can start to understand this. Of course, when we're dealing with HFrEF, there are many fewer women in general. With respect to sex-specific cutoffs, I think we're beginning to see that the data suggests that women do probably live at slightly different levels, that normal might be different for a man and a woman. We can't use these data for that. We have to look at the epidemiology. But it's pretty clear in Paragon that there was a treatment interaction with women that seemed to, that the curves were shifted with ejection fraction, so that while clearly people at the higher end did derive less benefit from this drug, women seem to derive benefit way into the 60s, whereas men definitely did not. And so I would personally believe that we should consider, if we're going to consider cutoffs in terms of therapy, we should take ejection fraction into account. Again, I don't love cutoffs, but I think taking ejection fraction into account is not a bad idea. How do we explain it? I can't tell you that we know the answer to that question. We did not look in Paragon at subsequent echocardiograms, so I can't tell you what happened with ejection fraction in these patients. There are some differences in natriuretic peptides. And we do know that there are some differences in the way women, especially postmenopausal women, respond to natriuretic peptides compared with men. Right now, it's conjecture. There's a whole lot of fantastic research that has to be done looking at these differences.
I have a comment regarding
and let me add that the men-women differences, although we saw it very clearly in Paragon, when we went back, we saw this in CHARM, we saw this in TopCat as well. So it's not just
consistent across different trials. Yes.
Yeah. Sorry.
Scott, we are in dilemma in heart failure with PEF reserved because of the number of ejection fraction. I mean, at the end you collect two trials, one with reduced, one preserved, in order to have a net result from for pretest probability. Let's change the definition of heart failure preserved ejection fraction into what's about longitudinal strain. You mentioned this, GLS, because we are concentrating only on the number of ejection fraction, but actually it's not, because the GLS is an important part for just prolonged or decreased GLS. So can we change the definition of the ejection fraction or the parameter of the function in order to reach the conclusion that this drug is efficient for patients with preserved or diastolic dysfunction, or we don't know anything?
It's a very good question. I mean, we have shown in our own group from multiple trials, including TopCat, Paramount, now Paragon, ARIC, that patients with HFpEF have reduced longitudinal strain, even if they have normal ejection fraction. And you know, I think that's an important point. You know, the heart doesn't just squeeze, it also twists and moves from the apex to the base. And when it does that, it's able to generate the stroke volume that's necessary because of that longitudinal motion. When they lose that longitudinal motion, they can't do that. So we think that abnormalities of longitudinal strain may be a better way to do it. So I would agree with you. I think it's going to be very hard to convince the world that has been paying attention to this one number, ejection fraction, for 40 years, to switch. But we've been arguing for some time that we need to move beyond ejection fraction and look at not only things like longitudinal strain, but also take into account some of the other things that we know about our patients, whether they have diabetes, their GFR, and so forth, in making determinations about what medicines and therapies to use.
Dr. Magdi.
Dr. Solomon, thank you very much for this highly informative presentation. In Paragon trial, the reduction of NT-proBNP was 19%. However, NT-proBNP did not identify patients who benefit more from sacubitril valsartan. This is the first question. The second question, the benefit of using this drug early after hospital discharge, patients who admitted with HFpEF. And the final question is regarding hypertension and HFpEF, which is a common cause of heart failure with preserved ejection fraction. And we know that in the SPRINT trial, they excluded heart failure patients. But the sub-analysis regarding the optimal blood pressure in those patients, is it 120 to 129 compared with more than 140? So the drug should be adjusted to obtain this blood pressure, systolic blood pressure level to gain the benefit in patients with HFpEF?
Okay, three complicated questions. So your first question about NT-proBNP. So you're absolutely right. NT-proBNP at baseline did not influence the benefit of the drug. By the way, it didn't influence the benefit of sacubitril valsartan in Paradigm with heart failure with reduced ejection fraction. We saw benefit regardless of where these patients' NT-proBNP was. I thought you were going to ask another question, which is you saw a benefit of NT-proBNP. How did that compare to the benefit that we saw in the hard outcomes? And I think that it was clearer in Paradigm. We saw the benefit of about 27% reduction in NT-proBNP and a 20% reduction in outcomes. Here we saw a 19% reduction in NT-proBNP and more like a 13% reduction in these outcomes. So there's a bit more of a disconnect, but still, I think that the NT-proBNP reduction does reflect the pathophysiology that we are affecting here. Now, with respect to blood pressure, it's a more complicated question because I don't know that we can answer what is the optimal blood pressure to get these patients to, although I would argue that we shouldn't use trials like this. We should use trials like SPRINT that have actually tested aggressive versus standard of care blood pressure reduction and use those data to help guide us. But you're right, those trials were not necessarily done in patients with heart failure with preserved ejection fraction. I'm not sure it's easy to get an answer to that question in a trial like Paragon because we force people to have relatively controlled blood pressures when they came into the study.
Can I just comment?
Yes. Okay.
Yes. Well, I enjoyed tremendously the presentation of Dr. Scott Solomon. And to me, the key word is that there is heterogeneous treatment for preserved ejection fraction. So I think maybe we're all trying to use all these agents that have failed, similar to reduced ejection fraction, instead of using precision medicine by, for example, trying to look at advanced image analysis, urine blood testing, tissue analysis, and then targeting each group, each phenotype with the proper therapy. Because as you know, we're not only targeting the heart, there is the lungs, the skeletal muscles, the kidneys, intestines, immune system with the IL-1, IL-10, endothelium, all these things. And these trials with drugs with the funny names, and these are my questions, do you expect them to show some positivity? I mean, the ones with the inorganic nitrates and nitrites, and they are all looking at surrogate endpoints, the soluble guanylate cyclase pathway and all the antifibrotic therapies, even the SGLT2 are the only ones that are really looking at hard endpoints. But the different phenotypes, everyone has a different treatment, like the pulmonary hypertension phenotype. They're looking at the drugs of pulmonary hypertension, the calcium handling, the mitochondrial dysfunction. All these were looking at surrogate endpoint, 6-minute walk tests, and changes in peak oxygen consumption. I mean, that's all what we have. It's a mix. So are we looking forward, this is my question, to any of these agents showing promise, or are we just going to be disappointed like all other agents?
Well, first of all, I think Dr. Busker is going to give a talk about precision, and she might cover some of these issues. But I think that there's no question in my mind that when we treat patients with heart failure, there is heterogeneity in the population, in the phenotypes. And as I said before, this is true in HFrEF as well as HFpEF. The thing is, in HFrEF, we can treat pretty much anybody for any reason that they have a reduced ejection fraction heart failure with beta blockers, ACE inhibitors, ARBs, ARNIs, MRAs, and so forth. They will respond for the most part to those drugs. I do think it's a little bit different in HFpEF, and I think we are beginning to understand that there are phenotypes. I mean, we can pull out the phenotypes for sure, but that there are phenotypes that may respond differently. And a few that I think we have to be, at this point in time, very cognizant of. Amyloid heart disease, for example, is, we probably had patients with amyloid heart disease in Paragon. It was an exclusion, but that doesn't mean we didn't have some who had unknown amyloid heart disease. Some of the data suggests that up to 13% of HFpEF patients might. If so, there are potentially targeted therapies that work, TTR stabilizers or knockdown agents in those patients. We're starting to see potential therapies for patients with hypertrophic cardiomyopathy, which is a subset, if you will, of HFpEF. So we're going to start pulling off some of these groups if we can recognize them, and we're certainly doing a lot more to try to recognize them. Otherwise, it's hard to do it, what you're suggesting, because you need enough patients to treat to see a benefit. So there are approaches that we might be able to use if we feel that we can identify a clear molecular or pathophysiologic mechanism in a given patient, and then target that mechanism. That would be very reasonable. We didn't go that route in HFrEF. We haven't so far gone that route in HFpEF, except for a few trials that, to be frank, have not yet worked. But I'm going to leave the rest to Dr. Bosker, because I think she's going to talk more about this topic.
Thank you very much, Scott Turmagdi. Thank you very much. Can you introduce the third speaker, please? Okay.
First of all, I'd like to thank my dear friends, Professor Sobhi and Professor Hassanin, for the kind invitation to participate in this elegant gathering. I'm delighted to join this distinguished faculty from US and Egypt, Professor Abataya as well. And now I have the pleasure to introduce Professor Bekim Busker, the Professor of Cardiology at Baylor College of Medicine, Houston, Texas. And she's the president of the Heart Failure Society of America. And she's going to present a very interesting subject, which is the need for precision in heart failure. Professor Bekim.
Thank you, Dr. Abdelhamid. Everybody can see my slides, I assume?
Yes.
Thank you. So that was a nice transition segue from Professor Solomon's discussion for the necessity for precision. I think the question posed by Professor Attia really sets the stage for us to discuss this concept. These are my disclosures. I'm going to start by a few cases and start by stating that most patients require standard guideline-directed heart failure therapy, but we have to always consider other concepts such as etiology, comorbidities, and other entities that I'm going to touch on in the next few minutes. So a 54-year-old man presenting with HFrEF, EF25, blood pressure fine, elevated BNP, low sodium, borderline elevated creatinine. We could consider the standard therapies, including RAS inhibition, beta blockade, ARNIs, SGLT2 inhibition. But if I were to tell you that this patient has presented with atrial fibrillation with rapid ventricular response rate and has been in tachycardia for a longer period of time than most heart failure patients are able to tolerate, we may target the etiology and try to treat the tachycardia along with initiation of the guideline-directed therapies. And if I were to tell you that this patient has features of amyloid beyond the HFpEF phenotype that we would have expected, now recognizing that this patient has transitioned from restrictive cardiomyopathy to a dilated phenotype, we would need to use specific treatment strategies for this patient beyond guideline-directed therapies. Now, our approaches to the heart failure treatment that currently exists starts with the overall definition of heart failure, which goes with the symptoms, which Dr. Butler and Dr. Solomon touched on, as well as the hemodynamic features of elevated filling pressures. Then we touched on this phenotype by EF of reduced EF, preserved EF, mid-range or recovered EF, partly due to the currently existing evidence demonstrating more benefit with neurohormonal antagonism in HFrEF patients. We also have something called stages of heart failure. Stage A, asymptomatic but at risk. Stage B, respective changes of asymptomatic symptoms. B, symptomatic, D, with advanced refractory heart failure. And if we were to start from the precision of prevention of heart failure, we now have evidence that this is one of the very important strategies. If you look at the guidelines, usually 4 features, 4 comorbidities are identified as the traditional risk factors for heart failure, and these include hypertension, coronary artery disease, diabetes, and obesity. Why only 4? Why not alcohol? Why not chemotherapy? The reason these 4 are commonly identified as a traditional is the relative risk being high and the population attributable risk being high. Thus, raises the emphasis on recognition of the burden with these comorbidities. So if we were to look at how many patients in the United States have heart failure, symptomatic heart failure diagnosis is somewhere between 6 and 7 million. But if I were to ask the question, how many patients have stage A or destined to have heart failure in the future? All of those comorbidities listed there, including prediabetes, diabetes, obesity, hypertension, which may equate to about 1/3 of the US population being in stage A heart failure. Why is this important? We now have evidence, as you have heard from the previous presenters, of benefit for reduction in future development of heart failure risk with SGLT2 inhibitors in patients with diabetes, which appears to be a class effect represented on this slide with empagliflozin, canagliflozin, dapagliflozin in EMPA-REG, CANVAS, and DECLARE-TIMI trials. 2 days ago, we saw from the VERTIS CV trial that was presented at the American Diabetes Association meeting that the heart failure reduction events were significant, but not the MACE events or cardiovascular death reduction, posing the problem that potentially these agents may vary in terms of their beneficial profile on the cardiovascular domain. But one thing for sure, the reduction in heart failure hospitalizations appears to be a class effect with SGLT2 inhibitors. So for those patients with diabetes, now we're faced with the dilemma of, is this patient destined to develop heart failure in the future versus atherosclerotic heart disease? And if so, whether the preference to use SGLT2 inhibitors versus other agents such as GLP-1 agonists versus SGLT2 inhibitors may come as a question. Raising the question of, can we predict who's going to develop heart failure in the future? And whether we need a strategy to define higher risk for heart failure than what we have traditionally called as stage A, with just existence of comorbidities. There have been studies, most recently risk profiling of diabetic patients. This was published end of 2019 with data from the SAVOR-TIMIT 53 as well as DECLARE heart failure trials. And as can be seen, the top panel demonstrates the classic features that we would see as heart failure risk: prior heart failure, atrial fibrillation, coronary artery disease, chronic kidney disease. The interesting feature over here is microalbuminuria, which actually conferred a significant risk for prediction of future heart failure. Not only were the investigators able to identify the future development of heart failure better, those patients who fulfilled this risk scoring actually benefited more from SGLT2 inhibition. Thus, they had a scorecard of prediction of who amongst the diabetics would benefit more for prevention of heart failure. I'm going to touch on another study. This is not a diabetes study. It was pretty much inclusion of many patients. The sample size was over 1,300 for patients with either established cardiovascular disease or hypertension or diabetes, who were randomized into two arms. One arm for natriuretic peptide screening annually, and then being followed by a multidisciplinary team that involved a cardiovascular specialist who then optimized therapies versus not natriuretic peptide screening strategy and pretty much a traditional approach. And as can be seen on this slide, the individuals who were randomized to the natriuretic peptide intervention arm, screening arm, and subsequent further imaging and subsequent optimization of neurohormonal antagonism, as can be seen on the left panel, had a significant reduction in MACE events. And on the right panel, as can be seen, they actually had reduction in asymptomatic development of LV dysfunction, as well as clinical combined endpoint of heart failure combined with LV dysfunction. We also have evidence from a study enrolling diabetic patients, smaller scale, 300 patients, and they actually randomized patients to NT-proBNP intervention arm versus control, and intensified therapies according to the natriuretic peptide screening levels. And as can be seen, the combined endpoint of cardiovascular hospitalization and cardiovascular death was significantly lower in the NP-targeted intervention arm. Both of these resulted in a recommendation in the 2017 focus update of AHA-ACC guidelines. As can be seen, in the aftermath of these two trials, the guideline authors had recommended natriuretic peptide biomarker-based screening, followed by team-based care, including a cardiovascular specialist optimizing guideline-directed medical therapy, to be a useful approach to prevent development of LV systolic dysfunction or diastolic dysfunction or new onset heart failure. This was stated as a class 2A indication. One can also consider such an approach perhaps for a variety of other etiologies that are known to be risk factors for future development of heart failure, such as chemotherapy, such as infectious etiologies such as COVID-19. And we usually diagnose these in the aftermath of symptoms and try to go back and look at the etiology. But now with the recognition of chemotherapy, immunomodulators, and or potential cardiotoxins and or a certain presentations or phenotypes being a significant risk for heart failure, there could be a possibility of utilizing perhaps biomarkers earlier. We now know that cardiac troponins, especially the high sensitivity troponin, actually predicts future development of heart failure. much more significantly than future risk of myocardial infarction. And thus, this could be a marker of maladaptive fibrosis or hypertrophy or heart failure development, and raises the question whether these biomarkers will identify a population at a higher risk for future risk of heart failure. Such a concept was utilized for an endpoint in one of the chemotherapy trials, looking at targeting individuals at risk with adriamycin therapy with breast cancer history and using carvedal or beta blockade, and then looking at the cardiac troponin I levels, demonstrating a significant reduction in the cardiac troponin I levels with the carvedal arm compared to the placebo arm. Thus, the concept that we currently face probably may entail recognition of a early stage B before we start identifying the futures of structural changes, either by echocardiography or by imaging, as we traditionally identified stage B, to an earlier stage B with elaboration of biomarkers, be it natriuretic peptides, or be it microalbuminuria in diabetes, or be it cardiac troponin I in the setting of potential injury and or exposure to cardiotoxicity, that can perhaps then allow us to utilize specific preventive treatment strategies, such as SGLT2 inhibitors, though in those patients who may be with microalbuminuria or others. And this paradigm shift may allow us to also move the field from treating LV systolic dysfunction or advanced heart failure at the time of symptoms to an earlier stage with consideration of neurohormonal antagonism at the time of the structural changes being discernible by biomarkers. And perhaps even the preventive strategies would then further focus on prevention of primordial risk rather than treatment of the risk in the aftermath. When we look at the necessity for precision for treatment of heart failure, when the syndrome of heart failure is there for the symptomatic heart failure patients, we need to target on treating the specific etiology in addition to or beyond the guideline-directed medical therapies. And the best example that comes to mind is cardiac amyloidosis. As Dr. Solomon has mentioned, a significant proportion, approximately 13-15% of our HEF patients, and even some of our HEF-REF patients, do have cardiac amyloidosis. And their treatment is not going to be the garden variety treatment of heart failure. Now we have evidence from specific targeted approaches, especially in the setting of TTR amyloidosis, to target the transthyretin. Now, the other thing I'm going to focus on is GDMT may be potentially harmful in amyloidosis patients. Diuresis needs to be done very judiciously and with caution, because the loss of preload can be detrimental. Beta blockers, especially if they result in bradycardia in a patient who is heart rate dependent with a fixed cardiac with a fixed stroke volume, can potentially be detrimental. And digoxin can be potentially detrimental in patients with amyloidosis because digoxin can bind to amyloid fibrils and can predispose to toxicity. So from that perspective, one size fits all can truly create a concern both for safety and loss of opportunity for targeted therapies for saving lives. If we look at the variety of diagnoses, which currently have specific treatment strategies, it's not only amyloidosis. We have the rapidly evolving field of cardio-oncology. We are aware of the expanding portfolio of cardiotoxicity with illicit drugs. And in the COVID era, we are definitely cognizant of the potential effects of viral infections. And yes, we do have the evolving portfolio of recognition of MINOCA, endothelial microvascular dysfunction, stress or Takotsubo cardiomyopathy, and tachycardia-induced cardiomyopathies. How do we perhaps focus on identifying, documenting, coding the diagnosis of heart failure? Currently, we're struggling with our specificity, even if when we are documenting symptomatic heart failure, because we're pretty much limited by the ICD-10 codes. Currently, even in the clinical trials, a majority of the patients who present with volume overload due to CKD or cirrhosis, if treated with IV diuretics, may be miscoded or miscategorized as heart failure. And we all know about the dilemma about what to do in the setting of cor pulmonale. Some of those patients are categorized as heart failure. And of course, the overlap between sleep apnea as well as obesity and the Pickwickian and the hyperventilation syndromes is a pretty challenging concept with overlap with heart failure. We currently state that we have approximately 26 to 34 million patients identified globally from large-scale registries reporting heart failure. That's with the traditional diagnosis of heart failure. And if you look at the overall population prevalence, that ranges somewhere between 1% to 2%. If we were to apply this to the remainder of the globe, we would have approximately 78 to 100 million people with symptomatic syndrome of heart failure. This does not capture cardiomyopathies. And if we look at what do we use for cardiomyopathies, and this is the ICD-10 code for cardiomyopathy utilized for hypertrophic non-obstructive or restrictive or idiopathic or secondary or familial cardiomyopathies. As you can see, the ICD-10 code is the same. Whereas we know that the treatment strategies or management strategies for each one of them may need to be different. The good news is, in the last 2 decades, if you were to focus on the lower panels, the prevalence of use of cardiomyopathy as a diagnosis is increasing. We've seen the surge between 1990 and 2017, but we are still seeing an increase in our recognition that there is such an entity as cardiomyopathy. And this probably is an interesting slide. This is from the most recent 2020 American Heart Association Heart Disease and Stroke Guidelines, which also provides global density maps. And as can be seen over here, the prevalence is highest for myocarditis and cardiomyopathy in Central Europe, which creates the question of whether this is the recognition, use of the code versus that truly is a representation of prevalence. And when we look at the death attributed to myocarditis, now we see Eastern Europe appears to have the highest rate of deaths attributable to cardiomyopathy and myocarditis. Of course, these may be due to our limitations in our electronic medical records or our registries or our coding systems, but truly raises the question of why are we not as advanced as what cancer has done? On the right lower panel, you are seeing the usual categorization used by cancer, which is the TNM. As you remember, the metastases, the nodes number, and the T level of a cancer being used as a nomenclature. This was attempted by a group of individuals who proposed such a classification for heart failure, utilizing the mnemonic of MOGIs. M standing for morphofunctional, meaning dilated, hypertrophic, restrictive, O for organ, G for genetic, E for etiology, S for stages. It was a good attempt, didn't have much of an intake, and had a focus on genetic. And the top code is their coding for what they would term for a patient. And if we were to try to decipher backwards, this is a patient with ARVC and with hypertrabeculation in terms of phenotype, with the organ being heart, without a positive family history, but 2 variants of different genes that is defined as an etiology. I must say that this is a good entity, probably with a focus on the genetic component, and incorporates different concepts that we struggle with, be it the phenotype of hypertrophic, restrictive versus dilated, but still probably is not good enough for us to be able to utilize in a routine practice. The question comes, in addition to the genetic profiling, do we use, or is there a role for further categorization among heart failure patients with utilization of the biomarkers? And we know that the natriuretic peptides get better with treatment in patients who get better. But the vice versa, meaning when the biomarkers get better, does the patient get better, which I will touch on in the next slide, does not appear to be the case. So what it means is most patients who improve with the strategies, either with diuretic or with neurohormonal antagonism, who are responders to therapy, will manifest by a decline in their natriuretic peptide levels. But when we try to treat the natriuretic peptide level itself beyond the clinical indications, as demonstrated by the guided heart failure trial, which was the largest scale trial, which failed to show any superiority with natriuretic peptide guided therapy amongst heart failure patients compared to the traditional usual care arm, which actually strategized to optimize guideline-directed medical therapy. So currently, there is no significant or clear or consistent evidence for improvement in mortality and cardiovascular outcomes by natriuretic peptide-guided therapy. And thus, in the most recent 2017 Focus Update guidelines, there is not a recommendation for targeting biomarkers beyond usual guideline-directed therapies in heart failure management. These are the recommendations, which states that the biomarkers could be used for diagnosis or exclusion for acute or chronic heart failure in the event clinically one cannot determine whether this is heart failure or not. And it also states that there is a role for biomarkers for establishing prognosis. And one can potentially obtain a pre-discharge natriuretic peptide level to add further to the prognosis. How about other biomarkers, such as the routine labs, such as creatinine? We know that worsening creatinine or worsening renal function is usually perceived as a prognostication that is associated with worse outcomes, but not exactly, not always. If a patient is decongested during acute decompensated heart failure admission, and at the time of discharge manifests no congestion symptoms, but has worsening renal function, along with optimized congestion status, that does not confer adverse outcome effect. So the patient who's diuresed during the hospitalization, whose creatinine bumps a little bit, but is decongested, has the same outcome as somebody who has not bumped their creatinine and doesn't have congestion at discharge. The ones who have congestion have worse outcomes. So what does this mean? A biomarker in one direction by itself may not be adequate, and thus will need to be taken into the context of clinical, other variables, as well as the individualization of that patient's baseline and response to therapies. If we were to go back to the question that Professor Attia posed, can we target risk profiles, phenotypes, mechanistic groups, or trajectories in patients with established heart failure beyond what we can do with GDMT? The concept is perplexing, partly because we do have numerous comorbidities and numerous phenotypes. One can define the clinical phenotypes as a top line, stable, frequent decompensated, biventricular failure, and or the comorbidities with diabetes, CKD, AFib, hypertension, and or other comorbidities as listed on this slide. Yes, we all have the art of individualization of therapies as to which one of the GDMT we start first and then up titrate next and look at the tolerability of the patient. The pheno mapping concept has been attempted for HFpEF, and this is an elegant study that has grouped the HFpEF patients into three. The phenogroup 1, young, low BNP, 2, obese, diabetic, 3, older individuals, sicker patients with CKD. But the other interesting thing is on the left upper panel, you see a color-coded mapping. And these entail, even though in fine print, numerous biomarkers, numerous lab markers, numerous clinical and echo markers. The feature that is of note is they have only two colors, either bad or good. Going up, red, going down, blue. But as I mentioned to you, sometimes creatinine going up with decongestion may be good. So we need a third dimension whenever we're trying to do artificial intelligence to put things in the right context. Not every creatinine rise may be a detrimental color code. So how to phenomap things that fits the pathophysiology is the challenge. And currently, AI may help us with this. The other strategy is to individualize therapies too. Most of the bedside physicians already do this. Patients' severity of illness and trajectory, goals of care discussions, tolerability, and others. Everybody states the reason for low intake or not being able to optimize therapies are not solely due to the physician inertia. But I would like to change this perhaps paradigm and state the following. There has been numerous studies looking into why is the patient not on guideline-directed therapies and why not on the optimal dose? Yes, payer coverage gap and high cost are issues. Yes, side effects and intolerance and non-compliance and comorbidities and patient-related concepts are issues. But when you look at the CHAMP registry and looking at the reasons, physician inertia appear to be the largest reason, the biggest domain reason of not being initiated on guideline-directed therapies. We need to definitely target this. And I added to the provider column inaccurate diagnosis as another reason. And we need to focus on those. And I will finalize by stating that we also need precision in safety. We now have newer treatment strategies in heart failure. I had mentioned that we need to recognize that diuretics have been with a reduced prevalence in most of the ARNI trials, as can be seen over here. Those who were randomized to sacubitril valsartan at month 6 or year 1 or year 2 in the Paradigm HF trial were on lower diuretic doses compared to the enalapril arm. And as I mentioned before, ARNI does appear to have an effect on the metabolic axis, and the hemoglobin A1C levels significantly were reduced at the end of the clinical trial in the Paradigm HF trial with sacubitril valsartan compared to enalapril. Then raises the question of the combination of ARNI with SGLT2 inhibitors, whether we will need to be a little bit cautious about anti-hyperglycemic effects or hypoglycemia. Both of them lower the blood pressure. We may need to watch the blood pressure closely, and probably we will need to reduce the diuretics. So these concepts, as they're evolving independently, though I will admit that in the DEPA-HF trial, 11% of the patients were on background therapy, and as Dr. Butler has demonstrated, the subgroup analysis, post-hoc analysis of ARNI versus no ARNI was not different with SGLT2 inhibitors. But be as it may, at the patient level, each of these drugs have a variety of package inserts for watching out or being very closely sort of under monitoring for certain patients. So volume contraction is one of those concepts that we need to watch out for with SGLT2 inhibitors, and thus the reduction of diuretics may need to be considered more seriously with ARNI and SGLT2 inhibition in a combined manner. I will finalize by stating that our approach to precision is not necessarily solely ordering some esoteric tests and or further imaging strategies, but in essence starts with creating the scaffold, which is the guideline-directed therapies, but then looking further and asking for the specific etiology and refining the treatment according to specific etiology, according to the patient's characteristics and patient's comorbidities, trajectories, goals, and potentially consideration of the other variables such as biomarkers. Thank you for your attention.
Thank you very much, Professor Pekin, for this amazing presentation. I have two questions. The first question regarding the imaging for detection of subclinical left ventricular dysfunction with the use of GLS, global longitudinal strain. The second question is the precision in elderly patients specifically. And finally, the cost effectiveness of this strategy in treatment. Thank you.
Great questions, Dr. Magdi. I will start with the first question, global longitudinal strain. We utilize the whole spectrum of our diagnostic testing. The art of medicine is, I don't think, is an EF cutoff. As we discussed, mid-range EF actually doesn't stay. Usually when you look at the history of the patients, those patients actually vary. They either go to the HFrEF or the HFpEF realm, and it's not a static value. And I agree with you, in especially those borderline cases or in cases where you want to detect this early, in those cases at risk for heart failure, such as cardiotoxicity, chemotherapy. In those individuals, many diagnostic modalities. We could do GLS, global longitudinal strain. We could do PET imaging. We could do perhaps the high resolution technique, other types of imaging. We're also finding out with amyloid, technetium pyrophosphate imaging. So I think in the art of medicine, it's a compilation of a variety of different diagnostic tests depending on the etiology. I do utilize GLS, for example, peripartum cardiomyopathy patients. The EF looks good, but the ventricle is borderline dilated. Is that due to the volume status? These patients have preload expansion. I look at the GLS. And in other individuals, such as chemotherapy patients, when their EF is in that borderline range of 50, of course, the global longitudinal strain in that setting is going to be very beneficial. Your second question about the elderly and the cost effectiveness. Elderly, I think, is a very important group of our patients. Majority of our patients are Medicare population age over 65. And in most of our guideline-directed medical therapies, when you look at subgroup analysis of age, consistently there is benefit. So the first message I would like to give is, do not refrain from optimizing therapies for elderly just because there is this perception of them being frail and so forth. The benefit is there. Same thing for device therapies. But there is a time during which we will need to consider whether there is a necessity for concession or elimination of certain agents. These could be individuals who are unable to tolerate. Yes, I do have a heart failure, advanced heart failure and transplant clinic. I do take care of patients with blood pressures of 80s. And yes, I do try to treat the patient rather than a number. But there are times when the advanced heart failure patients come to a level of terminal state where we find ourselves of reducing the doses because they're unable to tolerate larger doses. And at that point, I find myself of scaling down on the intensity of some of the therapies for quality of life, with the recognition that they may lose benefit from the perhaps the outcomes. In terms of cost effectiveness, most of the guideline-directed therapies have had subsequent publications demonstrating the cost benefit. AHA, ACC guidelines, I believe, will be targeting the cost analysis in the future guidelines, but I think this is an important concept that varies in different geographic populations. I am aware the access is quite different in different parts of the world. Surprisingly, some of the perhaps sites have full access to generics and or poly pills, and whereas universal health coverage differs in different nations, and thus we are to learn from each other. I think we definitely are at a position to see the differences of intake and see the success stories from other populations and societies as how successful they were to uptitrate guideline-directed therapies. One very humbling trend we have seen in this CHAMP registry, and then I did a review or editorial looking at most of the other registries, real-world population registries. In the last 2 decades, in the United States, we have not seen an increase in the percentage of beta blocker, ACE inhibitor, or ARB, MRA use in the US population in the real world population. Whereas we have consistently seen an improvement in the background therapies in our clinical trials. As Dr. Butler showed in the DAPA-HF, the RAS inhibition was 96% ACE inhibition combined with ARB or ARNI. Beta blockers were over 90%. But when you look at the real world practice, the registries, CHAMP registry, which was the most recent one, demonstrated that even though we saw slight improvements for a while, we have not. So we have a big inertia in non-optimization of GDMT in the real world population, and thus I think we'll need to examine the reasons.
Mikman, this is a wonderful lecture, as expected. A few years ago, there is a claim of what we are searching for in heart failure called target therapy, like the cancer. Do you think that we are not searching for that? We are going to personalize medicine, our guided GDT, GDT for coronary, GDT for heart failure. The terminology, you forget about it for the cardiologist, because those are oncologists speaking about target therapy. You are in the situation that we are in need of this, or just depending on what you said in the last slide?
I'm going to answer that similar to what cancer did. Cancer, when they embarked on this journey, they were treating it like a disease, like organ disease, like lung cancer, like liver cancer, and so forth. And partly because of the way the clinical trials are designed. And also, we attempted the pathophysiology, targeting pathophysiology. I have collaborated with Dr. Douglas Mann in targeting cytokines and TNF and so forth. And even the neurohormonal hypothesis, when we tried to measure the, those with high adrenergic, elaboration with epi levels, and try to use depleting agents for the adrenergic signaling, we failed miserably. And we tried to also work on inotropy, even with the oral agents, and we failed miserably. So my answer is, even though we attempted pathophysiology, probably our understanding of pathophysiology is not as precise. We then found ourselves being successful in certain phenotypes, which was HFrEF, heart failure with reduced EF. Then we started going back and say, this must be the reason, this must be the reason, and this must be the reason. We continued with that approach. I think, as cancer did, we're at that early phase of treating the phenotype. Probably as we get more understanding, maybe with a little bit more biobanking, artificial intelligence, ability to gather more of genetic profiling of our patients. With the conglomeration of this, like cancer did, we will be able to recognize the signals of response. So my answer to that is, yes, cancer went through that. They're not right now treating an organ. They're treating a cell line. Yeah. They're treating certain signaling. But they didn't start that way. So we're at the early organ and hemodynamic and pipe and secondary maladaptive sort of remediation phase, because we know the neurohormones are up. But as to what to do at the cardiac myocyte level, we don't know.
Thank you very much, Dr. Beckman. And now I'm shifting to Dr. Ihab Atiyah, I think, because out of time. And I think you leave for 10 minutes or something like that. You come back at the end. He told me this. But we have to to the end, please. Okay. Now, Dr. Ihab Atiyah. Off air. Okay. Then I have listen.
Can you see it now?
بس slideshow full screen.
It's clear.
I will introduce. Now I'd like to introduce my friend, colleague, well-known figure in cardiology, Professor Iyab Ataya, Professor of Cardiology in Shams University. After three eminent speakers, American speakers, speak about heart failure, reduced ejection fraction, preserved ejection fraction, the precision. Now looking for Dr. Iyab, the essential intervention and the case, and then we have to finish by conclusion. Dr. Iyab?
Yes, like I said, it's just going to be a short case. We don't have much time, so I'll go straight to the case. It's we have Mr. Kamal, who's a 58 years old male with known ischemic heart disease. He had 2 prior attacks of myocardial infarction. He had his RCA and LAD stented 5 years ago. He's hypertensive, was diagnosed with HFrEF with an ejection fraction of 25 3 years ago by his physician, and he has been hospitalized since then for acute heart failure. And during follow-up, his signs and symptoms started worsening. He presented at the clinic with shortness of breath, which was progressive over the past 5 days. He fatigues easily and says that he lost all his energy to do anything. The night before, he awoke suddenly from sleep because he couldn't catch his breath and developed a dry cough. He generally sleeps with 2 and sometimes 3 pillows. His lab results showed an impaired creatinine 1.4 with an eGFR that's moderately reduced. He's got a normal potassium and serum sodium. His HbA1c is within normal. His NT-proBNP is 1485, which is quite elevated. His LDL cholesterol is 85, which is not at target according to guidelines, and triglycerides is borderline at 154. On examination, his blood pressure was 105/70 with a heart rate of 65 with mild lower limb edema. He had bilateral fine basal rails with elevated JVP, and his apex was displaced downwards and outwards with an apical soft pan systolic murmur. So it's a classical presentation. And when we look at his EKG, he was in sinus rhythm. It showed an old anterior and inferior infarct. QRS duration was 130 milliseconds. He had an LA abnormality with very frequent multiform PVCs. His echo showed left ventricular enlargement and remodeling with marked segmental wall motion abnormalities, multiple areas, ejection fraction of about 25, enlarged left atrium, diastolic dysfunction, grade 2 mitral regurgitation with grade 3 tricuspid regurgitation, and an estimated right ventricular systolic pressure of around 60 millimeters mercury. He was on these medications when he presented. He was receiving enalapril 10 milligrams twice daily. He was at target dose of carvedilol 25 milligrams twice daily, eplerenone 50 milligrams, torsemide 20 milligrams daily, aspirin 100 milligram, rosuvastatin 20 milligrams, which I think will need to be increased by adding ezetimibe maybe for his LDL, or increasing the dose of rosuvastatin, whichever the physician will choose. And a CRTD was implanted for primary prevention of sudden cardiac death. So this was the presentation of Mr. Kamal, and this is quite a common case that we see presenting either to the EDs or to our clinics sometimes. The problem is, as we heard from all prior speakers, the burden of heart failure, and in this particular patient, I'm focusing on the cardiac remodeling, but we know that it is associated with abnormal neurohormonal regulation. So this leads to the high mortality and morbidity that we see in these patients. And every time he's going to be hospitalized, he's going to come out with a poorer prognosis, with further negative remodeling and worsening cardiac function with an enlarged left ventricular volume. So this remodeling is key in that patient. And Dr. Solomon has shown a long time ago in the Valiant Echo study, you all remember the Valiant Echo study, which studied the changes in left ventricular size and function in patients with left ventricular systolic dysfunction after myocardial infarction with valsartan and captopril, or even both at that time. And it showed quite elegantly that there is a relationship between these echo parameters and the outcome of death or hospitalization for heart failure. And you can see in the left side graphs, you see as the left ventricular ejection fraction goes down, you can see the effect it has on death and hospitalization, together with the increase in left ventricular end diastolic volume and end systolic volume. So this was shown elegantly by Dr. Solomon more than 15 years ago. Now we're interested in what the effect of Entresto, which is sacubitril valsartan, compared to RAS blockers on cardiac remodeling, only on that parameter. So this should answer the question whether early intervention with Entresto could delay or reverse cardiac remodeling. We are going to just go through these 5 small studies. Number of patients, maybe 660 in these 5 studies, different study periods ranging from 3 to 12 months. And it looked at specifically the reverse cardiac remodeling with Entresto, looking mainly at improvement in left ventricular ejection fraction, reduction in left ventricular end diastolic volume and end systolic volume. And what was important also is not only the volumes, but the change in shape and function of the mitral valve, with the important reduction in mitral valve regurgitation, as well as diastolic function improvement. What was interesting in these studies that about 56% of these patients had an ICD or CRT, quite a large number, maybe 245 patients out of these patients. When we look at the effect of Entresto on ejection fraction in these patients on top of the optimal medical therapy they were receiving, we can start by imagining that when they were on ACE inhibitors or ARBs, their ejection fraction increased by 1 to 4%. Beta blocker got a more impressive improvement in ejection fraction from 4 to 12, as well as MRAs. But when these were switched to ARNI and they looked at the ejection fraction, there was an average of 5% improvement in left ventricular ejection fraction. And this is when switching from a class 1 therapy like ACE inhibitor or ARB to another class 1 therapeutic agents such as ARNI, sacubitril, valsartan. So this was an important parameter. Again, like I said, we are always interested in the degree of mitral regurgitation because it has a direct relationship to the symptoms of the patient and his quality of life. Because we all know a patient with an ejection fraction of 25 without mitral regurgitation presents completely different than a similar ejection fraction patient with grade 3 mitral regurgitation. It's different presentation, and they keep coming to hospital more frequent. So if we have an agent, such as in this slide, that has a change in visually graded mitral valve regurgitation with a reduction in the degree of mitral regurgitation, that's of value and importance to our patient, mainly in his quality of life. And here I would like to point to a study by Professor Magdi Abdelhamid in University of Cairo, which was presented last year, and they looked at this parameter, and they showed also that with usage of sacubitril valsartan, there was an improvement in the degree of mitral regurgitation. So this, again, it's an important issue. Finally, I want to finish by showing you the proof heart failure, which we already heard from the previous speakers, but this was a biomarker study more directly. It was a phase 4 prospective. It's, of course, as you know, it's an open label study in patients with heart failure with reduced ejection fraction. It was a 12-month study, and they looked during this 12 months at the significant correlation between the concentration of the NT-proBNP and the cardiac remodeling parameters, namely the left ventricular ejection fraction, left ventricular end diastolic volume index, left ventricular end systolic volume index, left atrial volume index, and of course the EE prime, denoting diastolic function. And it was quite significant, the p-value, as you will see on the extreme right. All of it is below 0.001. And when we look at specifically this bar graph, we see the improvement in left ventricular ejection fraction from baseline to 12 months. And even when we look at a certain subset of patients, 25% of these subjects had an improvement in ejection fraction of more than 13% at 12 months, which is quite impressive. We can also appreciate the reduction in left ventricular and diastolic volume index and end systolic volume index together with left atrial volume index and improvement in diastolic function, as well as reduction of left ventricular mass index, which is important. And this gives us explanation that the improvement is coming from reverse cardiac remodeling, which is important to look at. Finally, I will go back to our patient, Mr. Kamal. What do we need to do to optimize his treatment? Like I said, one of the things we're going to add either the ezetimibe or increasing the dose of his statin. But more importantly, since we have so strong data, so I think what we offered him is we stopped enalapril for 36 hours before starting Entresto. And in this case, we started immediately with the 100 milligram twice daily. We didn't start with the 50. And it was up titrated after 2 weeks. We kept his MRA and other beta blockers and medication stable at the same dosages. And he started showing improvement in his symptoms with a better quality of life as early as 2 weeks after doing this treatment. So in conclusion, I mean, and this is my final slide, when we use heart failure pharmacotherapy, we want to look at the agents that have benefits on the three important parameters: survival, morbidity, and quality of life. And when we look at all these groups, the ACE inhibitors, the ARBs, and we find that they had benefit on survival and morbidity, but not much on quality of life. The beta blockers, the same. Diuretics, we know that no benefit on survival was proven. The MRAs, no benefit in quality of life. Ivabradine has no effect on or inconclusive evidence on survival. However, when we look at the ARNI with sacubitril valsartan, it satisfies the three parameters we're looking at. It has an important benefit on survival. We've seen that with the Paradigm heart failure study, and morbidity, heart failure hospitalization reduction, as well as improvement in quality of life, which has been shown repeatedly in studies with the Kansas City, of course, cardiomyopathy scoring. So this is a drug that should be used. And this brings us to the termination of this case, is that Entresto is an essential heart failure intervention. And we should not delay it, because since we know that it has these benefits, there is no sense to wait like the European guidelines used to say you can wait 6 months with ACE, ARB before you switch. I mean, why not just start from the very beginning, since we know we're going to get these benefits? And with this, I will conclude my presentation and will wait for your questions. Thank you.
Thank you, Ehab, very much. Ehab is actually with the 3 lectures, or the first, second lecture, and then your case, and then personalized. Yes, I think it's time now to personalize the patients, to give this drug from the beginning, because all the trials we go at the beginning, we have only one trial, Paradigm heart failure, and then prove it Pioneer, where patients following acute heart failure with the dry will evaluate regarding reverse remodeling, will prove it. So we have a lot of evidence of this drug, even quality of life, sudden death. So I think nowadays you have to start the drug. Do you think that we have the courage to make this, or you wait until the European will change the guidelines?
And I believe we should, and I believe that even since the guidelines came out, I mean, if you have data that shows there is an improvement in mortality, which is a hard endpoint, plus improvement in quality of life and all the other parameters, I mean, why should I wait and waste 6 months of my patient's life? Because some patients might not live these 6 months. You know that sudden death can happen at any time after initial diagnosis. They might not have the luxury of waiting 6 months until I decide whether I'm going to shift them or switch. They need to get the best treatment that I can offer from day one. And this is, I think this is my duty. This is what I should be doing. So with all respect to the European guidelines, I think that the way to go would to use everything I have and any new drugs that come up again, and we're waiting next year, maybe we'll have new data from the omecamtiv mecarbil. If we have any data that shows us drugs that improve survival, we're going to use it from day one. That's my opinion.
Yes, I have one question for Professor Atiyah. First, thank you for this great presentation. I know that your talk is mainly centered about Entresto, but would you consider sodium glucose transport inhibitor in your patient? Would this improve his chances of living longer and having a better quality of life?
Yeah, I would. It's an excellent question, and I would do this. I would add it with all the data, positive data we have. I would add it, but I would be cautious by reducing the dose of the diuretic when I do this. I will add it and reduce the dose of the
definitely
furosemide, and I would expect that that patient should do much better even. Yes, that's an excellent suggestion.
So you have tips and in using the ARNI or Entresto. Regarding the blood pressure, the EGFR, the fluids, the deterioration renal function, using ACE. You said ACE before you have 36 hours. If the patient was in full treatment of ACE or full treatment of ARBs, what dose you have? Can you tell us, summarize tips and tricks in using this drug?
Excellent question, because in this example, we did not start with the 50 milligrams because already the patient was receiving enalapril 10 milligrams twice daily, and he was tolerating it with the systolic blood pressure of 100, it was 105. So this encouraged us to go ahead to the dose and to upgrade quickly. If that would have been a situation, and we would have been cautious by starting with the 50 milligrams, maybe BID. Also, another issue is the
Internet.
You said the
I think it is be an unstable internet connection.
ممكن ما يصاب
I can help you. I can help you. Have number one, dose. If you start with, for example, a minimal dose of ACE, or for example, valsartan, a small dose, not optimum, you start with 50 twice a day, and then up titrate it. If it's a full dose, you start 100 twice daily and up titrate. Number two, you should take care of the potassium. Very important, the potassium, and also EGFR. If it's increasing, you have to decrease the dose. Don't give this drug if there is hypotension. So it's better to decrease diuretics in order to give this drug when the blood pressure is 100 or more. These are the tips and tricks of using this drug. Thank you, Dr. Ihab, for this wonderful case to end this. So is Dr. Baikman with us? Okay.
I'm back. Thank you.
Thank you. Magdi, are you with us?
Yeah.
We won't see your face. Magdi, I won't see your face. Okay. Okay, we start, Dr. Baikman, with the closing remarks before me.
Thank you. I would like to thank all the participants, Professor Sopi, Professor Hassanein, Professor Atiyah, and Professor Abdul Hamid, and also my colleagues from the United States, Professors Solomon and Butler. I think this was a very well-rounded discussion, looking at the whole spectrum, all the way from heart failure with reduced EF to preserved EF, how to individualize, and what to do with specific cases. And I'm hoping that our audience benefited from these discussions.
On behalf of myself and CBREP and all the group, Dr. Hassanein, Dr. Magdi, Dr. Ihab, I think we have 3 hours, not a 2.5, expected to be 2 hours, but extended to 3 hours. This is the first. So this can be something like the virtual. We can stay for 3 hours looking for all the eminent speakers. I think this depending on the quality. The quality of the lectures was excellent. It includes all types of, and you are not just a speaker, you are doing a PI of different trials. So this is the importance of your presence in these worldwide webinar. I think this is a role model webinar of the eminent speakers with eminent chairmen as well. We have a lot of questions with you, and also the attendee. The attendee have a lot of questions still waiting till now. I think I hope we succeeded to bring all the group with America. I know it's a personal invitation, but all of you are working or board members of the American Society of Heart Failure, and also at CVREP and the Egyptian Society of Cardiology. All of us, we are the group. We are working with the benefit of our patient. I think we succeeded in the virtual, and I hope to see you soon in person. Thank you very, very much, Dr. Mahmoud, Dr.
Thank you. Thank you.
Thank you very much. Thank you very much, Professor Sobhi.
Thank you very much. Thank you. Thank you, Professor Bosco. Thank you very much.
Professor Pekin, we enjoyed too much your presentation, and it was very, very interesting. Thank you very much. Thank you very much, Professor Ihab, for the elegant presentation as usual. Thank you. See you. Bye.
Bye-bye.
Bye-bye.